Hello, I'm Paul Lorigan. I'm a medical oncologist at the Christie Hospital in Manchester. I'm really flattered to be asked to talk at this meeting. I'm very grateful for the invitation. I was looking out to see a lot of faces I recognise, many of them friendly, some of them not, but not a problem. And I just want to really congratulate Imogen on organising an absolutely fabulous meeting. I know how much work goes into this, and it's a real credit to you. So I'm going to talk a bit more broadly about personalised medicine or personalised treatment for melanoma. I started treating patients with melanoma a long time ago in the mid-90s. And when I started then, we sort of viewed melanoma through a single lens. It was a form of skin cancer. We didn't know a lot more about it. We had the staging system. The best treatment was surgery, probably still is, in fact. And then our treatments, if it came back, were very poor indeed. And we didn't tend to subgroup patients at all. And of course, we've had these huge advances over the last 10 years or so based on understanding the biology of melanoma. And coming from that, we've developed these new treatments that you've been hearing about, the treatments that work on the signaling pathways, the communication pathways within the cells, and the treatments that work on the immune system and getting the immune system to target the cells. And with that, we've seen dramatic improvements in outcomes. But I think we still have a fairly one-size-fits-all approach to treating people. And that's not because we don't want to personalise treatment more. It's because we're just learning about how to do that. And so that's what I'm going to try and focus on. I think I've got more questions than answers. So in terms of personalised treatment for melanoma, what are the goals? What are we trying to achieve? Well, we want advice on treatment personalised to the individual. So that person who comes in to see you in your office, you want to be able to talk about them, specifically about them, and give as accurate advice on outcome or prognosis as possible. To do this realistically, we need to be able to do it in real time. It's no good saying, well, we've got all these fancy tests and we can send off your biopsy and I'll have an answer in 6 months' time, or I'll be able to make a treatment decision in 4 weeks or 6 weeks' time. We need to be able to do it in real time. And it's not just a one-stop analysis. So we need to be able to do this on an ongoing basis. As the situation changes, we need to be able to monitor and change things. And of course, it has to be evidence-based. It's not just one person's gut reaction as to what's important or what isn't. Now, I hesitate to do this, but I'm just going to give you a couple of the definitions that we use. You'll have heard us talking about these sort of things, and it's not complicated, but it's just to help you understand it a little bit. So we talk about biomarkers, and essentially that's anything that reflects what's going on. So your blood pressure could be a biomarker. Your blood sugar could be a biomarker. But in terms of cancer, we measure certain things, either in the tumour or in the blood, and they may reflect what's happening in the cancer. And then we talk about different types of biomarkers. And the two ones just that you'll hear are prognostic and predictive. So prognostic means it predicts the likelihood, what might happen, what the future holds. And predictive means it predicts the response to treatment. So that's quite different. A prognostic marker doesn't necessarily say what impact treatment will have on you, but a predictive one will. So the sorts of things that we measure, if you just take it broadly, you can look here, you'll see I've grouped it into things about the person, so our age, our gender, how fit we are. All of these things predict our outcome from treatment for cancer. How widely advanced the cancer is, the bugs that we carry around in our body, they have an impact as well. And then there are certain things about us that develop on treatment that might predict how well we are responding to treatment. So if we're getting side effects from immunotherapy, that's likely to predict if you're getting a response as well. So there are things you can look at the patient, the person, and say, these things are going to help me make a decision about if you're likely to benefit or not. We can measure things in the blood. We mentioned earlier ctDNA, and I'm going to come back to that in a few minutes. And then we can also measure things in the tumor. So we look at the tumor, we do all the mutation testing you've just heard the elegant talk about, but also this, PD-L1, these other biomarkers, things that might help us predict whether people respond to treatment or not. So I spend most of my time dealing with people who've got advanced melanoma or who have very high-risk melanoma. But in fact, when you look at the melanoma burden across the UK, in fact, there are far more people who have low-risk melanoma than high-risk melanoma. So, and far fewer, again, who have advanced disease. And so it's important, actually, for us to also consider those people who've had a melanoma resected, what their risk of recurrence is. Now, why is that important? So I've titled this slide The Low Risk Paradox. And on the column on the right-hand side, on the left-hand side, you'll see tumor thickness. So this is essentially someone who had a melanoma removed, and we measured the depth of it, or the root of it. You'll have probably heard of this, the Breslow thickness. And the thinner the melanoma, the less likely it is to come back. So you see there the 0.1 to 1 millimeter. So these are the thinnest melanomas. And as an oncologist, if I saw you, I'd say, you're very unlikely to run into problems again. You can see there the 5-year survival. So your chance of being alive in 5 years are nearly 100%. Okay, so I might dismiss you and say, you don't really need to worry. The chances of you running into further problems are not very high. But there are two big series here, one from Queensland and one from the US. And if you look then at the people who, from those two big series, one of them 13,000 patients and the other nearly 50,000 patients. If you look at those two series and you look at the number of people who died from melanoma, you'll see that the low-risk group contributes significantly to that. So whilst the individual risk is actually low, there are still people who will recur and will develop metastatic disease and will die of that. And I think that's one area we really need to focus on. Now, so what are the tools we have at present for predicting your likelihood of recurrence? We've got the AJCC staging system. You'll probably be familiar with this. This is, looking at features of the tumor, features of the lymph nodes, and it's a snapshot taken at that time where the tumor was removed. But it doesn't really include any sort of biological characteristics. It's very much more morphological, or what the appearance of the tumor down the microscope, and also, if it had spread to the lymph glands. I'm highlighting this really to say that there are a lot of new predictors coming through, and there are these molecular predictors that are looking at the biology of the tumor and looking at that to see if that can add to the sort of anatomical staging with the AJCC staging system. And I'm also flagging up here vitamin D because it's a question we get asked about all the time, and it's something we don't really understand very well. We know that it correlates with tumor risk. So I want to just flag up two things. One, I'm doing this because many of you, if you've had a melanoma removed, I expect you'll go online, you'll look for information about it. And one of the things that comes up now is this DecisionDX-Melanoma. It's a prognostic tool. It's a test that can be done. It's actually licensed in the US. It's based on a gene signature, and it classifies people into low risk or high risk. It's commercially driven. It costs about $7,000 to have it done. And, if you'd asked me about it a year ago, I was very skeptical about it, actually. But I think that the evidence is accruing to support not necessarily this test, but tests similar to this. And I think that these are the sort of tests we are going to be using in addition to the staging system to try and identify those low and intermediate risk people who then go on to develop metastatic disease at a later stage. But it still does need further validation. But I think the next year or two we're going to see a big difference in that, actually, just to sort of flag that one up for you. And then the other thorny question is about vitamin D, and we do get asked about this a lot. So just to summarize my understanding of vitamin D, so there's no evidence at present from the studies that we've done that it's preventative. In other words, if you take vitamin D, it doesn't reduce your risk of getting melanoma. That's what the evidence would suggest. Okay. we can't be 100% certain about that, but that's what the evidence would suggest. What the evidence also shows that if you have low vitamin D levels, and most of us do, particularly in the winter, then if you have a melanoma, it's more likely to be a higher risk melanoma. But there's conflicting evidence on whether those people who have melanoma and a low vitamin D level have a worse outcome. So there are 3 studies. 2 of them showed a survival disadvantage. 1 of them didn't show survival disadvantage. Now, I think most people are coming around to thinking that it probably does, but I think the evidence is not yet conclusive. And we don't yet know, actually, what the link is between vitamin D and melanoma. Is it a surrogate? You'll have heard the analogy before of, in areas of deprivation where it's the number of TV aerials or the number of chimneys, it used to be in Victorian times, correlated with risk of tuberculosis. And it wasn't that chimneys caused tuberculosis, it was that chimneys were a surrogate for overcrowding, and overcrowding was associated with tuberculosis. So is it a surrogate, or is it a real biological biomarker? And I think it's probably the latter. There are trials ongoing looking to see if replacing vitamin D, if your vitamin D levels are low, reduce your risk. I'm not sure that those studies are ever going to recruit because people vote with their feet. Vitamin D is cheap, it's easy to take, and most people will take it if the vitamin D levels are low. And certainly the UK guidelines for people with melanoma say that, if you've got low vitamin D levels, you should replace them. But that's not general, internationally, and the NCCN, the big US guidelines, don't say that. So that's all I'm going to say about primary melanoma. I'm happy to try and take questions about adjuvant therapy, etc., in the question time afterwards. What about advanced disease, the area that I work in most of the time? So we don't slap ourselves on the back and congratulate ourselves about how much we've achieved, but we are quite pleased with what has happened over the last 5 or 6 years. But this is the survival curve. So if you're familiar with looking at these, this is 10 minutes. On the bottom, you've got time, and on the y-axis, you've got survival. And what you can see is that with time, people die. And what this curve shows you is that at 2 years, 50% of people with advanced melanoma will be dead because of their melanoma. And so that's not good enough, really, and we need to improve on that. Previously, if I'd seen a melanoma patient, say with a BRAF mutation, if 2 patients had come into the room, I would have probably given them the same advice. I would have said, this treatment, targeted therapy, will have this impact on you. But now we know, actually, that not everybody with a BRAF mutation is the same. And we can actually look at various factors about them and predict more accurately how well or badly they're likely to do with treatment. And what I'm just showing you here is, so this was over 600 patients, and you can break people down by the sort of biomarkers I talked about earlier. So one of the blood tests we measure, lactate dehydrogenase. We look at performance status, so what they can do, number of sites where the cancer has spread to. And if you look at the 2 boxes I've highlighted in red, you can see there's a 10-fold difference here in your chance of being alive at 3 years, depending on that sort of how the cards have fallen in terms of how your cancer is. So one size does not fit all for these people, and just recommending targeted therapy because you've got this BRAF mutation isn't necessarily the right thing to do. And this is an elegant bit of work that James Larkin did with my colleague Richard Murray in Manchester. And this is a patient, a young man with metastatic melanoma, and they biopsied. He's got 5 different metastases there, and they biopsied those, and then they did the sophisticated mutation analysis that has been talked about earlier. And they looked at the mutations in the different tumors. And what you can see is that there are a number of shared mutations. So the 5 different metastatic sites, so one in the lung, one in the arm, one in the liver, etc., had the same mutations, had many of the same mutations. But they also, the individual sites, had their own private mutations. And that may well account for why, some sites respond to treatment and others don't. And I think what I'm trying to get across here is this heterogeneity, this variation within an individual even of the tumors around the body, and we need to be able to better understand that to personalize treatment. So how do we go about it? So put simply here in this cartoon, You see somebody, you do your tests, your fancy sophisticated tests, you treat them then, and then the minute you start treating them, the cancer is going to start to change. It evolves. It's a sort of Darwinian evolution. There's a selective pressure applied to it. The strong cells grow out, they change, and then they become resistant. And so you need to be doing this all along. You need to be retesting, changing your treatment, retesting. But that's easier said than done, because if many of you will have been through biopsies, and doing biopsies, it's not a very easy thing to do technically. It's very unpleasant for many people, and it's very difficult to do sequential biopsies. 1 or 2 you might be able to do, 5 or 6 you'll really struggle with. So what's the platform then? What can we do to try and personalize treatment for people? And this is the sort of things we use. So on the top, we do the pathology. We look at the sample. We've got these other much more sophisticated things where we actually put some of the tumor into an animal, into a mouse. We grow the tumor in the mouse. It's a human tumor in the mouse, and then we can treat it, see how it responds, treat it with a new drug, etc. We can isolate the tumor cells from the blood and put those into the mouse and do the same sort of thing. We can grow cell lines. But the main thing that we're focusing on at present is this, it was mentioned earlier, circulating tumor DNA. So this is something that comes from the tumor. It comes from all the tumors around the body, and it goes into the bloodstream, and then if you can analyze that, you can detect that and you can analyze that, and then you can make decisions based on that. So I'm just repeating the data that was shown about the adjuvant study that was presented at ASCO this year by Becky Lee, who's a PhD student of mine, in conjunction with Mark Middleton and with Pippa Corrie, where we, for the first time, have shown that if you can measure ctDNA in people who've had their melanomas resected, and it predicts the risk of recurrence. So we're very excited about this, and as Pippa said, we're moving this forward very quickly. In the advanced disease setting, we can use this to monitor response to treatment. So if you look at the panel on the left, this was a patient was treated with targeted therapy. And if you look at the blue line, that's the DNA, and it dropped very quickly as the patient responded. But then they started to progress. And you can see below that there's a little red line. And we were able to pick up the mutation that was causing the resistance in that patient, and we were able to respond to that. Now, that's ideally what we would do, but it's not possible to do for everybody. We're starting out with a trial now based on biomarkers circulating DNA. So this is for people who have a melanoma and they have a BRAF mutation. And we're going to monitor the levels in their bloodstream on every 2 weeks. And once the levels drop, we think probably the right thing to do is to switch those patients to immunotherapy at that stage to see whether we can sort of get them fit with targeted therapy, and then when they're in the best position, switch them at that stage to immunotherapy. So that's a plan, a study that we're about to start. We've got a number of other studies that we're doing as well. So in terms of conclusions here, I think personalised treatment in melanoma, it's not yet a standard of care. We're really knocking on the door there, but it's not yet a standard of care. It does require new skills because there's a huge amount of molecular genetics that you need to use and interpretation of data, and so it's going to need a new skill set into the team as well. It is resource intensive, but hopefully it's going to be cost effective, because if you can target treatments properly, then people live for longer, and people living for longer is very cost effective. And I do think it's got huge potential to improve outcomes both in the adjuvant setting and in advanced disease. The challenges are, in fact, the technology is ahead of our treatments. So we can often pick up a mutation or 2 mutations, and we can say, if we can target that, almost certainly, that person is going to respond. But 1, we don't necessarily can't access the drugs to do that. And 2, often it requires a combination of 2 drugs that we have never combined before, and we don't know whether it's safe to give it. So there are a lot of issues that we need to address. And then we have the real-time decision-making challenges as well. Can we turn around the tests in time? So I'll finish there. I just wanted to point out to you the new patient decision aid that Melanoma Focus has released today. I think you'll have got from all the clinicians talking here, we struggle to make decisions at times, about what's the right treatment. I think I always say in 3 or 4 years' time we're going to be a lot wiser, I'm not sure whether that's the case, but, we do struggle to make decisions, and it's a huge amount of information to try and get across. And I know how hard it is for people. We've all got sort of been at this for a number of years, but for people coming to this for the first time, it's a lot. And I think the patient decision aid will help people. It'll help us as clinicians. It'll help patients navigate their way through those treatment decisions, know the questions to ask, know what they might be is going to be talked about. So we're really excited about that. So just if you would have a look at that. And I'm very grateful to you for your attention and happy to take questions. Thank you.